Hello, and welcome to our program today about COVID-19 and the homeless. My name is Chris Adams. I am the Director of Training for the National Press Foundation. I would normally be coming to you from NPF's Evelyn Y. Davis studios. Instead, like all of our panelists here, I'm coming to you from a spare bedroom in my house. I do have an E.Y. Davis coffee mug with me though, so that's where that's where we normally would be. What we're doing today is having a discussion about coverage of COVID-19 and the most vulnerable populations in our country. We're going to talk about homelessness, people experiencing homelessness, how they are impacted by COVID-19, what the unique circumstances that they face are, how public health officials can get a handle on that, and then how reporters can cover that issue. This is going to be the first of 3 webinars that we have on this issue of covering COVID-19 and the most vulnerable populations. Today, we have with us 3 expert speakers. We have Dr. Bechara Choucair, who is Senior Vice President and Chief Health Officer for Kaiser Permanente. We have Bobby Watts, who is the Chief Executive Officer of the National Health Care for the Homeless Council. And we have Hannah Dreier, who is a national reporter for the Washington Post, who 2 weeks ago did a fabulous story about outreach to the homeless population in San Antonio. So she's going to talk about coverage of that issue, coverage of that story, and give some tips on how to cover the homeless population in general. The way this Zoom webinar will work is we will hear from our 3 speakers, Dr. Choucair first, Bobby Watts second, Hannah Dreier third, and then we will take questions from you on Zoom. I'm watching the Zoom attendees sign on. We had, I can tell that majority of you are on the Zoom call already, but it looks like some are still coming in. But we're going to get started here with the program. When it comes time for Q&A, you have the ability to raise your hand, to type in a question, and there's the ability to ask a question via video as well. Once I've heard from all 3 speakers, then we'll start going to the questions. You should be able to see the other questions that are coming in, and you can upvote those, and so I kind of know what the most important or popular or interesting questions are out there. So with that, I'd like to reintroduce Dr. Bechara Choucair, Senior Vice President and Chief Health Officer for Kaiser Permanente, based out of Oakland, California, but they have operations in several states around the country. Dr. Choucair also has experience as the Public Health Commissioner for the City of Chicago. And so he's going to talk about this coming from his perspective as a public health official and now as somebody who is with a major healthcare system. So Dr. Choucair, I was hoping you could give us an overview of the COVID-19 pandemic and how it affects the homeless population.
Great. Thank you so much, Chris. And thank you, everybody, for joining us. And I'll be providing an overview of where COVID-19 is at this point and what are the direct implications on vulnerable populations, particularly folks experiencing homelessness. The next slide really puts what we know is so relevant at this point. As we are all aware, the COVID-19 pandemic is a severe and emergent health crisis globally. In many parts of the United States are already feeling the severe impact of this crisis. And we, unfortunately, all need to anticipate and prepare for this trend to continue for the next few weeks at least. I'm going to spend a few minutes level setting on what COVID-19 means for the homeless population in particular, and how what happens on the ground for this specific population affects us all. Because I think, as you all agree, the health of our nation and its unsheltered population are inseparably linked. The ripple effects of a COVID-19 pandemic among our homeless neighbors will have widespread impact, and that will especially be pronounced for the hospitals we rely on to keep us well. And because we don't have strong data on testing it's impossible to know how widespread COVID pandemic has been in our own communities. We do know, however, that as of this morning, we're having more and more cases. Even the slide deck that was prepared yesterday, as of this morning, we actually have over 143,500 confirmed cases. We have over 2,575 deaths, and we have almost 5,000 people who recovered already here in the United States. And based on the information that's available, we also know that the case fatality rate of between 1 and 2.5%, which means at the low end of the estimate, COVID-19 is almost 10 times deadlier than the flu. Every single day, we learn more about this virus and we make best decisions on how to be able to respond. And for our conversation today, it's helpful to first share an overview of how pandemic response works at the public health level, and then second, look at how it plays out for people who are experiencing homelessness in our own communities. In reality, as you see on the slide, we haven't seen this disease before, but we have seen pandemics. And we have hundreds of years of history to draw from. So while it may not seem like there was a precedence for this moment, we actually have some historical context to inform our understanding of what to expect next and how to prepare. In fact, what we know about pandemics, we have learned from previous pandemics, whether it's the 1918 flu pandemic that killed almost 50 million people across the world, or the 1957, 1958 pandemic that killed almost 1 million people, or the 1968 pandemic that killed also about 1 million people. We know we've learned a lot about pandemics in the past. And there's in reality about 4 main stages that a pandemic goes through. When an outbreak starts, we focus on containment. When containment fails, we shift to mitigation. When mitigation works, now we need to double down and focus on suppression, and then prevention is the 4th stage of any pandemic. So I'm gonna give a quick overview of what these 4 stages are and what do they mean for our homeless population. So when a new novel outbreak comes out, what happens is we really need to focus on containment. And what containment means is you want to identify the outbreak and try to contain it and prevent it from spread. And there are multiple strategies that we have in place to make that happen. Quick identification is key for containment to work. And the quicker you identify an outbreak, the more likely you'll be able to contain it, which means you have to be able to do testing fairly quickly to be able to contain that. Some of the strategies that we have in our toolbox for containment phase, first is isolation, also quarantine, and then contact tracing. And I know there's an important differentiation between isolation and quarantine. I know sometimes we hear those terms and we could think about them together. The reality is isolation is for people who are confirmed cases or presumptive cases. And it's really important that you identify those folks and isolate them, separate them from those who are healthy, so you can contain the outbreak. And you could isolate folks in their own homes, you could isolate them in hospitals or in designated healthcare facilities. And usually isolation is voluntary, but sometimes it could be enforced by federal, state, or local government. The other strategy in containment is quarantine. And this is really about separating people who are not ill yet, but they've been exposed to those who are diagnosed. And this could be furloughed healthcare workers or those who are experiencing symptoms who've been in touch with folks. And quarantining is really most likely happens at a home. And you'd want to make sure that if those folks who are quarantined become symptomatic, you have to be able to test them and put them in isolation if needed. The other key strategy in the containment phase of any pandemic is really around contact tracing. If somebody tests positive, you have to go out and figure out who they've been in contact with and really try to test them, evaluate them, quarantine them if needed, and then if they turn positive, isolate them. So those are the strategies that we think about in that containment phase. So as you think about the homeless population in this phase, testing and notification are more difficult for people experiencing homelessness. So is contact tracing. And as you can imagine, isolation or quarantining in a shelter or an encampment is nearly impossible. So that's that first phase of any outbreak that needs to happen. Now, when containment fails, and when you start seeing more and more community spread, we shift into what we call mitigation. And the whole purpose of mitigation is to really slow the progression of the spread in the community. And why is that important? For three things. One, you want to try to ready up our healthcare system to be able to support increased demand. Two, you want to try to slow as much as possible the community spread. So hopefully you develop treatments that might be helpful, as well as potentially develop a vaccine that might be helpful. And when a novel pandemic potential emerges and you're moving into mitigation, we have to layer a broad range of non-pharmaceutical interventions at a time when the vaccine and the pharmaceutical interventions are not available. And you really, so in addition to isolation, quarantining, and contact tracing, we start thinking about measures like school and university closures, closing of other venues, canceling large events. We start thinking about social distancing, particularly focused on those who are most vulnerable. In the case here of COVID-19, it's people who are over the age of 60, people with chronic medical problems, people with specifically respiratory issues, third trimester pregnant women. So you really start identifying these vulnerable population and make sure you're advancing social distancing strategies for them. Or as we've seen in a big chunk of our country, you do shelter in place orders, and if needed, you could do lockdown strategies as needed. So those mitigation strategies are critical to help slow the spread. And as you can imagine, for a homeless population, it becomes really hard to be able to advance and execute on these strategies. If you think about social distancing, for example, staying at least 6 feet away from other people is a pretty big challenge if you are staying in a shelter where beds are lined up end to end with dozens of people sleeping in the same room. Now, as the number of new cases go down, which we're expecting that eventually, because of all of our mitigation efforts, the number of new cases will go down, then we shift to what we call the suppression stage. And that's when suppression stage strategies must be deployed. So when the viral transmission is slowed, the new infection rate now is at a manageable rate, the community can resume some key containment efforts with contact tracing and imposing tracking, quarantine, isolation of the affected population. Key factor to make this happen is broad testing. Like, we have to be able to test as many people as possible so that immediately we jump on cases that are bubbling up, so we can really focus on those cases, contain, isolate folks, quarantine folks, and continue to test more and more people. And as suppression stages, and as you can imagine, there are lots of potential challenges to make that happen for folks who are living on in shelters, people living in encampments, people out on the streets, to be able to do the contact tracing, the isolation. Now, once we are fairly aggressive and fairly successful at suppressing the virus, suppressing the community spread, we really have to be aggressively thinking about prevention. And that would include a full range of prevention techniques that include, the vaccines. By that time, hopefully we'll have them available, treatments of outbreaks and others, treatments, modalities that might be available. And that prevention is going to be key to prevent an uptick of new cases down the line. The next slide, so those are the 4 stages that I think is important for folks to be aware of and why it's so challenging for folks experiencing homelessness. So let's look at the COVID-19 and the homeless population. So when it comes to COVID-19, homelessness magnifies the risks to individuals, largely because their living conditions make any of the strategies we've just talked about more difficult to implement without fast planning and effective coordination. In a new publication that just came out actually on the 20th of this month that looked at projections of the impact of COVID-19 on folks experiencing homelessness, we do expect that the homeless individuals will be twice as likely to be hospitalized compared to those who are housed, 2 to 4 times more likely to require critical care than folks who are housed, and 2 to 3 times more likely to die compared to the general population. And these estimates are based in part because of what we know is the higher likelihood of pre-existing conditions and other factors like weakened immunities, as well as significant barriers to basic sanitations. And then in the last slide, before I'll turn over to Bobby, obviously there are major obstacles for this vulnerable population at every stage. And we need to be able to have a coordinated response that takes this reality into account. Where can people be housed or treated in isolation if they are confirmed to have COVID-19 or they've been exposed to the disease? How can sheltered populations adhere to social distancing guidelines if shelters are not adequately prepared? We know that the homeless are at a greater risk for getting COVID-19. They are more likely to have severe cases due to those underlying medical conditions we talked about, as well as the poor living conditions. Creating adequate and humane shelter for people living unsheltered and reconfiguring existing facilities to accommodate social distancing and isolate symptomatic individuals become urgently necessary and a moral imperative. But the truth is, a cornerstone of the strategy for reducing the infection and transmission rates for everyone is to find key successful strategies for those of us who are living on the streets. And in reality, allowing people to live on the streets, unsheltered, in poor condition, is not the right thing to do for our fellow human beings, and is a threat to us all, because it will allow the virus to continue to spread in the community while the rest of us are sheltering in place. So with that, I'll turn over back to Chris so that we can introduce Bobby to talk a little bit about the work that the National Healthcare for the Homeless Council has been doing, and I look forward to the conversation.
Okay, Dr. Choucair, thank you very much. For our listeners out there, we are getting some questions in. We will, we've had one question come in on text. We've had one person who has raised their hand. And so when we are through with all 3 speakers, we'll start to turn to those questioners. And if you are raising your hand, you're allowed to ask you're able to ask your question via Zoom. Or if you're just submitting the question by text, I will ask the relevant panel or all 3 panelists about that particular question. So we are going to turn now to Bobby Watts, the Chief Executive Officer for the National Healthcare for the Homeless Council. He is based in Nashville with the council. Bobby began his work with people experiencing homelessness as a staff member for the New York City Rescue Mission in Manhattan. And so he knows New York very well, which is now the epicenter of the COVID crisis. So we're going to hear Mr. Watts talk about the homeless population specifically and the unique challenges it faces right now. So, Bobby?
Thank you very much, Chris. And I really want to thank the National Press Foundation for their interest in this important topic. And also want to thank Bechara for his great introduction to this. So I want to first just state that I am bringing the wisdom of the collective body of the council to this conversation. And next slide, please. And just to tell you what the council is really, I think it's helpful to look at our mission statement. And it is that grounded in human rights and social justice, the council's mission is to build an equitable, high-quality health system through training, research, and advocacy in the movement to end homelessness. We really look at this as homelessness itself as an epidemic that is unacceptable, as a public health crisis, as a human rights crisis, and we want to do something about it. And all that we do is really geared towards hopefully ending homelessness. Next slide, please. So the council really is an association. I like to say it is a miraculous gathering. It is a container for the 300 healthcare for the homeless programs, each of which are federally qualified health centers. So they are community health centers, but with an extra emphasis on meeting the needs of people experiencing homelessness. There are 300 of them, at least one in every state. And we also deal with medical respite programs, which I'll talk a little bit about. So again, we do training, research, and policy analysis and advocacy, because we realize we're going to end homelessness. It's not only through treating people, meeting their healthcare needs, we really need systemic change in our public policies. Next slide, please. We're missing slides, but I'll just kind of summarize what's there. So the National we are really, much of what we do is empowered by the National Consumer Advisory Board. And that is that we want to be informed by people with lived experience of homelessness. I've now taken to call it lived expertise of homelessness. We have, in business, the number one rule is if you want to succeed, it is listen to your customers. And in healthcare, we do a pretty poor job of that. And even in homeless services, we do a pretty poor job of that. So what the council does with their 1,400 members of the National Consumer Advisory Board is to work with those 300 healthcare for the homeless programs and the medical respite programs to make sure that the systems are in place, that they are listening to their customers, and that the customers have the tools to raise their issues. That is the best way for quality improvement. I was the executive director of a healthcare for the homeless program in New York City for many years. And most of our great ideas came from listening to people with the lived expertise of homelessness. Another part of the council is our clinicians network, about 2,000 clinicians, doctors, nurses, social workers in the healthcare for the homeless programs, in the medical respite programs on the front line, inform what we do. And one of the things they did that I found to be extremely helpful when I was running a healthcare for the homeless program, would always give it to my chief medical officer, make sure it got to all of our staff, was to adapt clinical guidelines. For instance, as Bechara mentioned, it's harder to treat people for any condition if someone is unsheltered. So right now we've taken the guidelines for treating diabetes. We've adapted that for how do you take into account that someone is maybe living in a shelter or on the street. How can you help them take their insulin? How can you help them think through how can it be stored? All those things you don't have to deal with someone who's housed. We're now also adapting it for the COVID-19 response. Next slide. Oh, I'm sorry, stay there. Also, a big part is the Respite Care Providers Network, about 1,500 members who work in medical respite programs across the country. And medical respite is a service or a facility for people who are experiencing homelessness, but don't have a clinical reason to stay in the hospital. So they would normally then be discharged back to their shelters, back to their friend's couch or to the street, all of which are conditions that will not allow them to heal. So they would end up back in the emergency room, back in the hospital, damaging their health further and putting in a tremendous stress and cost for the healthcare system. So I want to move to some of the really important things. And that is that when we're thinking of an epidemic, people experiencing homelessness are more at risk than they are a risk. This is not the first epidemic that we've had to deal with people experiencing homelessness, as Bechara mentioned. We've been through TB epidemics, we've been through HIV epidemics, and we are currently going through an opioid epidemic. And we must not forget that, because as we are responding to COVID-19, I really say we're dealing with multiple epidemics at once. Again, homelessness itself should be viewed as an epidemic. Then the levels of homelessness in the United States, in the richest country on earth, is a public health crisis, and it really is unacceptable. And now we are dealing with the COVID-19 epidemic. So when these two epidemics are meeting together, we see that there is a danger as of ever having a reservoir of disease existing in a population anywhere. We want to balance the concern that we want to make sure that people are getting care who are experiencing homelessness. Foremost, because they are at risk because of the weakened immune systems due to the effects of chronic stress, the living conditions of homelessness, being exposed to the elements, not having a safe place to live. All that is stress. Chronic sleep deprivation leads to a weakened immune system. So a homeless person who is in contact with comes into contact with the virus is much more likely to develop disease. And then if they come into contact with a healthy person, a normally housed person, that person may be exposed, but they won't develop the disease. But we don't want any kind of reservoir to exist in a population, because it can also spread then to the general population as well. So balancing that nuance, that homeless people are more at risk than they are a risk, is important when we're covering the stories. One of the things with our National Consumer Advisory Boards is we've trained speakers who have lived experience of homelessness of how to tell their stories. And when we listen to them, it really puts into sharp relief the conditions under which they lived, the difficulty they had in receiving care from the mainstream health system, and the importance of getting care. Next slide, people. Excuse me. So, yes, what we do to address an epidemic is what we should do to prevent future epidemics. So what we have done when we dealt with HIV epidemic among people experiencing homelessness, one of the things we found that the most effective intervention was to make sure they had access to health care and that they had access to housing. The federal government created special housing programs for people who were living with HIV and AIDS, because they realized without that housing, they could not develop, they could not treat the conditions sufficiently, and they would relapse. They would have difficulty in getting well, and much increased death rates. The same, now we are doing things in response to this epidemic. Was mentioning now every city is wrestling with how can they create isolation spaces for people experiencing homelessness. Some are doing it in shelters, expanding the shelters, opening up new shelters. Some are renting motel rooms. This is such an important public health intervention to isolate and quarantine, and I really appreciate Bechara's explaining that from a public health officer's point of view and the differences. We have called for, and we are seeing more medical screening in congregate settings. And we are also seeing more medical outreach to those who are unsheltered, whether on the streets, living in their cars, or in encampments. Several cities, in response to this, have said we are going to put out more hand washing stations for unsheltered throughout the cities, but especially encampments. This is an effective public health strategy. The CDC's #1 recommendation is to wash your hands frequently. How can you do that if you're living on the street without that? Now, this was first done on a wide-scale basis in response to a hepatitis A outbreak among people experiencing homelessness, first in San Diego in 2017, where they put in bathroom facilities, porta potties, and hand washing stations. That is an effective response to an epidemic, but that should always be going on if we're going to prevent future epidemics. These are basic human needs that our society is not providing, and we should, not only for human rights, but also for public health. The idea of shelter should always be thinking about how can we have a space to isolate people. Next slide, people. Excuse me, next slide. And the COVID-19 epidemic, and I want to end here, has brought into sharp relief the weaknesses and inequities of our health and housing systems. The virus does not respect state boundary lines, but whether you live on one side of a state line or not can greatly affect whether or not you will get access to health care. There are 36 states that have expanded Medicaid in response to the Affordable Care Act. There are 14 that have not. I come from and lived all of my life and worked in this field in New York City, which has always, even before the Affordable Care Act, covered single adults who are poor. I now live in Tennessee. When I go do work as a volunteer doing outreach, I see so much needs. When I visit encampments, so much medical needs, and know there's very limited options for that person to get the care if they don't have Medicaid. Even if they make it to a healthcare for the homeless program or a community health center, when they need to refer them to a specialist, the options are greatly reduced. We also see that race inequity is exacerbated. People who are poor, who are homeless, that dynamic has largely been driven by racism and the history of racism in our country. And as we are seeing the stress put on the system, we're very concerned that those who will be left out will be those who are poor, those who are homeless, those who will be racial minorities. Not having universal health care, not having affordable housing for those who need it, as most developed countries have done, actually all except the United States. We're seeing that this epidemic has just exacerbated and brought into sharp relief those inequities. As we move forward to preventing future epidemics, we can lessen those inequities. And I really want to thank you for your time and look forward to hearing from Hannah Dreier and the conversation.
Okay, so thank you. Our listeners viewers out there, if I saw a couple hands go up and then went down, so if you do want to ask a question, you can stick your hands back up and we will work those questions in. And then we will start to take some questions from our listeners out there, our viewers out there. Let me ask one quick question, and then we will, then it will go to Hannah. So this is, I think this would be for Bobby Watts. So this is from one of our viewers. So are you seeing shelters closing down because they can't follow guidance of less than 10 people gathering? Or are they staying open because they're essential, even though they're struggling to be safe and have a healthy environment? So what are the biggest struggles of shelters right now?
Yeah, the biggest struggle of shelters are largely health related and space related. How do you screen people coming in if there aren't enough tests? How do you, where can you find places to isolate and quarantine those that need to be? So again, cities are taking creative responsive, renting motel rooms, opening up new shelters. I have heard here in Nashville, the Nashville Rescue Mission has reduced their census so they can have more space between. But where do those people go? And that's what the Nashville government is trying to do. They are opening up another shelter. I have heard that some shelters that are not government run or funded, that are largely faith-based or run by small churches, have had to shut down, even though the great need is greater, because they operate by volunteers. Those volunteers may need to self-isolate themselves. So it is this is, again, the clash of two epidemics, homelessness, and now it's been exacerbated by this epidemic, by this pandemic.
Okay, so we will take more questions after we hear from Hannah Dreier. So if you have a question for any of the panelists, raise your hand or submit the question and we will get to them either way. So we now turn to Hannah Dreier, who is a national reporter for the Washington Post. She won a Pulitzer Prize last year for a different feature story, but I invited her. She won that when she was with ProPublica. I invited her here because of the story that she did a little over a week ago, in which she went out on the streets in San Antonio with outreach workers who were trying to reach the homeless in San Antonio. It's an interesting way the story came about, and how she was able to execute the story, including traveling to San Antonio just before everything went on lockdown. So I will turn it over to Hannah, and I was hoping you could tell us how this story came together, Hannah.
Yeah, thanks so much for having me here. So, like Bobby was saying, this crisis has sort of underlined a lot of social ills that we try to cover as reporters. And one of the things that I started thinking about with my editor was the way that it was showing how little of a social safety net there is for people who are experiencing homelessness. And you could see in DC, as people started to stay home, it was like a tide was going out. And suddenly we were seeing almost nobody on the street except for homeless people. And so we thought that it made sense to try to spend some time figuring out how to do a feature story about this issue. And the first thing I did was I looked at national data about homelessness. HUD has some good data that breaks down homelessness by county. And I started looking at where there were a lot of homeless people and not a lot of news coverage. So we thought about maybe trying to go to San Jose or New York City. Those seem like the places most likely to have coronavirus among like in a homeless encampment or in a shelter. But we decided there's actually a lot of coverage there already. That's probably not the most useful thing to do right now. And in the end, I sort of narrowed it down to Miami or Phoenix or San Antonio. And I called around to homeless shelters and like continuums of care. And everybody was very welcoming. This was the easiest story to report as far as access. But it was, there were just sort of like things in these other places that were red flags to me. Like Miami was about to have spring break, and it seemed like it could become a spring break story. In Phoenix, I hadn't really seen anything, and it was just business as normal. And in San Antonio, I talked to this outreach worker who was going out, and she just told me a little bit about what the day before had been like for her. I think we talked on Sunday, and she told me that Friday she had saved somebody who was having a heart attack, and somebody had tried to commit suicide in the homeless shelter, and just like all these sort of wild things had happened. And it was clear that she was just seeing really dramatic stuff every day. And so we decided that we'd focus the story in San Antonio. And so that was Sunday morning that I talked to this outreach worker. Sunday night, I was in San Antonio. I spent all of Monday following this woman around, and that's sort of what the story ended up being. So I followed her to her first call, which was a business owner who was worried about a homeless man who was staying outside of her business spreading coronavirus. And she wouldn't talk to him. He didn't really know what the virus was. And she started the process of trying to get him into the shelter. And it sort of became clear to her during the course of the day that getting into a shelter is not necessarily going to be the safest thing for people right now. So I got to sort of watch her change her approach. So in the morning, she was trying to encourage everyone to come in. She was shaking hands. She was explaining to people what coronavirus was. And by the evening, she had started keeping her distance. And she was switched to just sort of informing people about what the pandemic is. And she had stopped trying so aggressively to get them to come into the shelter. Because in the shelter, there were, hundreds of people all clumped together. People in this shelter are sleeping less than 6 inches apart. I saw a warehouse where there are just these thin mats laid down on the concrete, and like Bob was talking about, they're touching head to head, and there's just a tiny strip of space between them. And so it's so unclear right now what outreach workers should even be doing. But I'm really glad that we were able, before the post sort of put us all on even more lockdown than we were, to go out and explain a little bit about what a day in the life of an outreach worker is. So I was there for a day and a half, and then I came back and the story was out the following Sunday. So it was about a week from figuring out that we wanted to do the story to getting it in the paper. And then I have a couple tips on slides. Thanks. So just first talking about how we did this story. Whenever you can, I think it's important to have data here, especially right now. Like, people don't really understand the scope of the homeless crisis in this country. And some data nobody is tracking. So with this story, when we published it, homeless people in 5 states had been tested positive for coronavirus. That's just something I had to put together myself. I think 2 homeless people had died of the virus. And that was easy to put together just looking at news clips and releases from public health organizations. I feel really strongly that people, especially now, do not want to read about the most vulnerable populations. Everybody is sort of looking inward. You can see it on the Washington Post website, like the stories that people are reading are stories that sort of go to, what should I be worried about? How can I protect my family? And so I think now more than ever, it's really important to find a strong protagonist that can pull you through a story. In this case, we used this outreach worker. Like, we just tracked the day that this outreach worker had. And I think that helped the story connect with readers. And the other thing I tried to do in this story was emphasize that the homeless people who this outreach worker was talking to were making their own choices. So I think in some coverage of homeless people, you have the problem that homeless people are treated as passive victims who are just sort of subject to all of these structural problems. And that's not how people are. People make their own choices. People are always trying to do the best for themselves. And so we encountered people who were deciding to stay out on the streets because they thought that was safest. We encountered people who were working really hard to get into senior housing, and I tried to emphasize all of that. And then, I mean, as reporters, I think we have to be so careful right now about when we go out into the field. So me and my editor talked a lot about whether I should go out on this story. I think that's best practice right now. If there's a story that can be done over the phone, it should be done over the phone. And then if you do go out, there are a lot of guides going around, some from reporters who did Ebola coverage, about how to protect yourself and how to protect your sources. So some things that hadn't occurred to me is that your notebook can be contaminated. So it's important to treat your pen and your notebook and everything you have in the field with you as if it's been exposed. Same goes for your shoes. This outreach worker was constantly Lysoling her shoes, and your clothes. The outreach worker who I followed sometimes just throws away her clothes. And I've seen that as advice. Like, if you are out in the field, even if you don't think you've been contaminated, like, you have to treat your clothes as if they have been. The other thing I tried to do was report outside as much as possible. So it's strange, but reporting out in the street right now is actually probably safer than reporting inside a homeless shelter, because there's just so much, like, people are so packed into shelters. So I tried to report in open spaces as much as possible. And the most important thing is just to be always thinking, like, you could be carrying the virus. I flew for this story, so I tried to be really conscious of the fact that I could have been exposed and not know it. And the worst thing would be to give a bunch of people who, as we've heard, are already likely immunocompromised, who are often elderly, the virus without knowing it myself. So I tried to keep my distance as much as possible, and just be really mindful of keeping sources safe.
Okay, so you got back on the Tuesday night, and then have you been in quarantine, self-quarantine since then?
That's right. So I got back on Tuesday. I'm able to do this today because I'm still in quarantine. I can't go out on another story until tomorrow. They're keeping everybody who goes out in quarantine for 14 days.
And I am seeing, in this morning's papers, for example, I saw bylines from datelines from Post reporters elsewhere outside of DC. Are people still traveling, or are those all correspondents, or do you have a sense, what are the ground rules for Post reporters right now?
People are still traveling. It's such a fraught time, because I think the situation in China shows us that it's essential that reporters are able to do their jobs and get information out. And so we're trying to be mindful about what stories really require us to travel. You'll see that most Post stories right now are being reported over the phone. There's very little seen on the ground reporting. But I know that we have somebody in New Orleans, and it was dangerous to fly there, but it's essential that we have somebody on the ground in New Orleans. And So we're still traveling, and there's no firm guidelines about what story rises to the level that it's worth going out on right now.
Okay. So, so we have plenty of time for some questions. So our viewers out there, if you have a question, you can raise your hand, and I will work in some of those questions. I do have a couple of questions here that came in, Kaiser-related questions for Dr. Choucair. Dr. Choucair, can homeless people get tested in your facilities? If people aren't a part of your health system, is there anything that you are doing to help them? What happens when people show up in emergency rooms, for example?
Thanks, Chris. I think at this point, we do have testing capabilities to a specific, with specific criteria. We're obviously focusing on testing, particularly those who are most sick, who are admitted to the hospitals with symptoms consistent with COVID. So this is a group that we absolutely want to test. We're also testing people with symptoms who have chronic conditions. We're also focusing on pregnant women with third trimester pregnancies. This is the group that we're focusing on the most. Also, we're focusing on healthcare workers. So that's the focus right now. And as more tests become available, we'll be able to test more people.
Okay. And another question for Dr. Choucair. Is Kaiser contributing data from their off-label drug repurposing use anywhere? Is it possible, could they send basic info to the FDA or NCAT's real-time database, which is anxious for further case reports? Is that something you can address?
I'm not the right person to address this question, but I'll take it back to our teams, and then we'll try to get the right answer. If we have the right person who asked this question, we'll follow up after this webinar.
Okay. So this is a question from Sarah Rez Grossman. What are the stories you feel the media is not telling yet that should be about how homeless people are being impacted? Is it that the shelters aren't being enough tools to isolate and protect the homeless? Is it waiting to see more cases of homeless people having confirmed COVID-19 and covering how those populations are projected to be twice as likely to get it and be hospitalized or die from it? And as Hannah mentioned, it feels like everyone is being affected, so the bar to get people's attention to others' plights feels higher. What do you wish people would know about what's going on and how this is affecting homeless people? I guess I'm opening that up to any of the panelists, but basically, what stories dealing with the homeless need to be told right now that aren't being told? Bobby, is that something you could tackle?
Yeah, I'm sure everyone has a thought on it. There's so many. I mean, clearly I think probably the most important is for the needs for every locality to figure out where will they isolate and quarantine people experiencing homelessness who have been exposed or are suspected. That is the number one question. Leaving people in congregate settings without sufficient space or without the resources is a public health threat. People who are in encampments where you say, well, they're out in the air. Well, many people in encampments share tents, or if not, they share personal items. So how can you increase the space and make sure hygiene is done? Every city has to be struggling with that and needs to come up with an answer.
Okay. Any other big picture stories that aren't being mentioned, Hannah or Dr. Choucair, that you could talk about?
I'll say that for me, my personal bar, right? I mean, right now I'm in quarantine, so I can't do anything. But I think that what journalists can do right now is really accountability stories. And I think we're all having to shift from focusing on what is going to connect with readers to focusing on what stories are essential and need to be told to hold institutions to account. And I will say that just a couple minutes ago, somebody sent me a local report from San Antonio, a follow-up story from our story that says that the shelter in San Antonio has implemented new policies after a Washington Post article sounds alarms. And so I think with stories about vulnerable populations right now, like, it's possible that they're going to get lost in just the absolute, garden hose of news. but they can still create meaningful changes at the local level. And so that's what I'm trying to focus on. And I think a lot of reporters are trying to focus on as we grapple with what kind of journalism even makes sense to do right now.
Okay.
I think a couple of things I would add, Chris, here to what Bobby and Hannah mentioned. I do want to highlight the importance of telling the stories of the frontline workers who are doing the outreach on encampments, shelters, people out on the streets. I think Hannah told Monica Garcia's story so beautifully, and I think those stories need to be told. And I know Bobby and I both done outreach work in our careers, and that type of work is so critical. The other piece I think that's going to be important is we all know that the CARES Act has set aside a total of $12.4 billion in new HUD programs, ensuring housing stability for low-income households and for vulnerable homeless population. And that also includes a $4 billion in emergency shelter grants. And we know that this law mandates that those dollars must start flowing in 30 days or less. I think stories on how these dollars are flowing, how these dollars are making an impact on people's lives, people who are out on the streets, people at risk of homelessness, which is a huge population that's likely going to increase now that we're starting to see unemployment go up significantly. I think these types of stories are so important. I also want to highlight a couple of other provisions in the CARES Act that also, I think, telling stories about how those are implemented will be really important, particularly around foreclosure and eviction protections. You know, the 60-day moratorium on all foreclosures tied to any federally backed mortgages, the halting of most evictions for renters. I think these types of stories that tell how this act is implemented would be really, really helpful.
Okay. So let's go to some more questions here from Marissa Parisi. Is the coronavirus negatively affecting treatment for other medical conditions that the homeless population needs? Is treatment for other conditions still as available?
Yeah.
I think
I'm happy to take that
sure.
on if you want. I mean, we know now there is we're already seeing a global shortage, for example, for hydroxychloroquine and chloroquine. And over the past few weeks, these drugs have been identified as having a potential beneficial impact on the treatment of COVID-19 patients. So we're starting to see a significant rise in demand for those drugs, and supplies from drug manufacturers for these drugs have not yet caught up. So we're going to keep a very close eye to see how that shortage might impact current people who are on these drugs, like people who have rheumatoid arthritis, psoriasis, or others, and try to figure out what would be alternative, good, solid options for those folks as that shortage is being addressed.
Okay. All right. We have a question from Nancy West. New Hampshire is under a state of emergency. Is it the responsibility of the governor or commissioner of Health and Human Services to make sure homeless people get tested and quarantined if need be? What are the first steps the government must take immediately relative to homeless people? And then how do we get the word to homeless people? What are their legal rights? Can they be quarantined against their will? Bobby, is that something you could tackle?
Sure, I can begin. And I certainly think it is the responsibility of the governor and commissioner of public health to protect the health of all residents in any state. So yes, it is their responsibility to come up with a plan. I've been very pleased that the council was consulted, and some of our thoughts and suggestions were incorporated into guidance by HUD and by CDC about how to help communities, shelters respond to this infection. And one of them really is that there really needs to be a thoughtful way, again, for finding places to isolate and quarantine people experiencing homelessness. Also, San Jose is one city that has put a moratorium on encampment sweeps during this time. That was also a recommendation that was in the CDC's guidelines. So there are things that should be aware of. And people who are experiencing homelessness are residents of and citizens of this country, just like everyone else. They have the same, they should have this, they do have the same rights. They're not always enforced. So if there is a need to quarantine them based upon public health guidance that applies to everyone else, yes, but they should not be singled out because of their lack of a stable residence.
Okay. So we have a question from Colin Colchamiro. How are resources for those experiencing homelessness shared with that population? How can communities ensure that those who need the resources know that the resources are there? And then finally, what can the general population do to support individuals experiencing homelessness who are being adversely impacted by COVID-19? So I guess this is basically an outreach question. Possibly Dr. Choucair or Mr. Watts, if you could, either of you could tackle that one.
I can start, and then Bobby, feel free to weigh in as well. I think one thing to keep in mind is, as we're seeing cities and counties and states respond, they do have a response system that includes the creations of these command centers that coordinate the response to the pandemic in a certain locality. And it's really important that each one of these command centers have a group that's focused on homelessness, supporting outreach workers, supporting shelters, supporting people out on the streets, in encampments, or in shelters. And coordinating that effort is a critical function that these command centers need to be focusing on. And we're seeing that across pretty much all of our footprint, where the cities or counties or state command centers are paying special attention to this population. I think coordination of the response through these command centers is the most important thing we can do at this point to respond to the need of those vulnerable folks. Bobby, feel free to add anything else you want to add.
I'll just state the importance of that, because the tendency is for systems to overlook people experiencing homelessness in everyday planning, but especially in times of crisis. So doing that ahead of time, incorporating shelters and people experiencing homelessness and healthcare for the homeless programs and the overall emergency preparedness plan is essential.
Okay. Another question here. This is for Bobby. Can you talk, this is another outreach question. Can you talk a little bit more about what different cities are doing to reach out to the homeless populations? Is there a sense of what the best strategy is that cities should, or some cities are employing?
Yes, some cities always have had outreach teams, either funded by the local government or just by nonprofits. And when there are continua of care that incorporate those street outreach teams into the overall structure of homelessness response, that is important. One of the requests for public policy requests for the council with this to respond to this emergency is that there be more emphasis on putting on street outreach to those who are unsheltered, as well as what's called in-reach. Because someone may be in a shelter doesn't mean that they're going to get the information or that they will be, they still need to be reached out to. So best practices are really to incorporate it into a larger citywide effort. There's street medicine, there are many healthcare for the homeless programs use mobile health clinics, and they are being deployed and employed to respond to those who would normally be outside the scope of mainstream healthcare. Those efforts are being stepped up.
Okay.
Chris, can I
Sure.
add?
Yes.
So some cities are pulling people off of the streets at the same time that other cities are ramping this up. So in San Antonio, the outreach worker I followed, Monica Garcia, was the only person still working on the street by the time I finished that reporting. And she herself is now thinking about staying home. Police are staying home. So in some places, the response is ramping up, but in some places, people are just stepping off and staying inside. And I think that's something we're going to see really ripple through this population.
Okay, this is kind of a related question. This will probably be our last question here. This is from Nancy West. How should states reach out and test homeless people? Should the state make hotel rooms available? So I guess any of you has any sense of what is working in other states, and has a hotel issue come up?
I'm happy to start here, and Hannah and Bobby, feel free to to add. I think the key issue here is about the importance of doing broad testing. I can't stress how important this is in general, and particularly for the homeless population. The reality is we build our work based on data, and a key element to helping us understand what the data is, where the community spread is happening, how widespread the community infection rates are. Really, this is based on testing. And if we don't step up testing significantly as a country, this is going to be really, really hard to help us get into the suppression stage and then into prevention. So I think testing is so critical. And I know many cities, counties, and states are looking at hotel room as an option to support for isolation, quarantining. I think this is a very, very good, positive approach to help people who don't have any other options to be able to self-isolate or self-quarantine.
Okay. So anything to add to that, Hannah or Bobby?
Yeah, I mean, one thing that I think it's important to keep in mind, especially for local reporters, is that homeless people have been left out of the federal stimulus packages so far. The first two stimulus packages had nothing for outreach workers, for shelters, for hotel rooms, for self-isolation. And so one thing that I heard over and over again is that cities and counties feel like they've really been left on their own here.